Hello, everyone, and welcome to our fourth live virtual drop-in session with Professor Probhodana Ranaweera, held in collaboration with Moms in Colombo Facebook page. As you know, women hold families and societies together. They nurture the next generation, they support their homes, and they also contribute so much to the economy. However, in doing all this, they often tend to forget to care for themselves and look after their own well being as well. But their health and well being is important not just for themselves, but also to keep the society in strength. So that's why we are here today to answer the questions asked by women about their own health and well being. And we won't be able to do that without our amazing obstetrician and gynecologist extraordinaire, Professor Probhodana Ranaweera, who is always willing to educate women and empower them. So without further ado, let's welcome our very own doctor. Welcome, Professor.
Good evening, and thank you, Taruka, once again for organizing this. So hopefully we'll have a good session today.
Yes, and it's been a while, but it's also our very first live session since you got your professorship. So congratulations on that. And we are honored to have you here as well. All right, let's get started because we do have a lot of questions today lined up. But I just want to quickly remind all our viewers, if you do have any questions, you can type in your questions in the chat as well. Although they no longer will be anonymous, but we will try to answer some of them as well. But I can assure you, we do have an array of questions listed today. All right, doctor, let's get to the first question. So this lady is talking about polycystic ovarian syndrome, and she's saying, for someone with PCOS who starts having almost regular periods after weight loss, is it possible for ovarian cysts to shrink and the ovaries to appear normal on ultrasound? And can PCOS ever go away, or is it generally considered a lifelong condition? So in answering this question, please also explain how this is diagnosed properly by a doctor and what are the key differences between PCOS and ovarian cyst as well, doctor.
Right, okay, so that's a good question. Now a lot of patients, or rather the people who are suffering from polycystic ovarian syndrome. Now, the first thing I like to emphasize, now we have been telling this again and again. Now, polycystic ovarian syndrome is not a disease. That's the number one thing. So, if you don't have a disease, you can't be cured. And the question, like whether this can be taken away, whether it's get normal. So what happens is, it's like now as Asians, our hair is black. A Caucasian may have a blonde hair. It's a genetic thing. So there's our system is run through genes and proteins and things like that, enzymes and all that. So what happens is, in the basic way, there is a mutation in a gene, or we don't know that gene or the cluster of genes. What does it make a fat layer and the muscle layer of a woman to become resistant towards insulin? So in other words, they have a higher insulin level rather than a low insulin levels. So that is why they deplete their insulin stores very quickly and then can become diabetic. So they have a insulin resistance. So they secrete more insulin. So when you secrete more insulin, number one thing happens, insulin is a hormone which secretes when when you eat. So its primary task is to absorb carbohydrates and store carbohydrates. So obviously, if the insulin levels are high, that person is going to absorb more carbohydrate and store more. So they can become, they gain weight quickly. Now, a lot of like people who are suffering from polycystic ovarian syndrome usually say that they don't eat and gain weight, but that's not true. So number one is that you have to understand that if you eat carbohydrates, carbohydrate is sugar or carbohydrates. So if you eat sugar, it absorb and go to the liver, become fat, and then store in the body. Similarly, if you eat carbohydrates in the gut, it changes into sugar and then goes to the same thing, fat and store. And we have a almost unlimited capacity to store fat. That's why a 2-ton weight man living in the world, right? So the more you eat or more carbohydrate you eat, more the storage. So what happens in polycystic ovarian syndrome is, so you have more insulin, so you gain weight quickly, and anybody who's like doesn't have polycystic ovarian eat a lot, and then after a certain level they become insulin resistant. So they again start to have more insulin, So they go to this vicious cycle of having more insulin, more weight gain, more insulin resistance, more insulin, more weight gain. So they go to a vicious cycle. So they become heavy. That's number one. Number two is when the insulin levels are high, the testosterone levels goes up. Testosterone level is the hormone of men. Men has a lot, women has a little. But when the levels are high, they start to have this cosmetic effect. Hair growth, balding, what you call pimples or acne. They start to have those and more of a male kind of things happening. And of course, this we can do or we can treat it with what we call cosmetic ways. Like if you have hair, you can wax and things like that. But the more important thing is when the testosterone levels are high, a growing egg will stop growing. So it's toxic. So then another egg starts growing, it stops again. So if you look at these ovaries, the small eggs are there. So it's not a cyst. It's the developing eggs has halted at one point, and when we do the scans, we see it like a polycystic ovary. Now, when women had this period problem, they came to gynecologist first, and we did the scan. We saw this polycystic. Now, we did a study on, there's a study in the world where a normal ovary, which one with a nice one egg, we injected testosterone. After a while, this sheep ovaries become polycystic. We stopped injecting testosterone, they became normal again. So basically, there's nothing wrong with the ovary. It's basically if your testosterone level are high, your periods are going to be further apart, because until you ovulate, and if there's no conception, within 14 days, you will have a period. So time taken to develop an egg will have issue. So this is what happening to this a bit of a, I can do a lecture for our on polycystic ovarian syndrome, how to manage it. So basically, if you come to, if as the person who was asking, if you lose your weight, you lose what we call your insulin resistance, and you become normal. Now, again, as humans, we are all in a biological, we call it a Gaussian curve, right? So even somebody very tall can be normal, somebody short can be also normal. So majority are 5 feet, something like that. So basically, there is a cutoff. Some women, when they are 50 kilograms, they become 60 kilograms. They have all the features of polycystic. If somebody has, let's say, another woman, when we gain about 90 only have that polycystic features. So you have to find your level. And once you go down that level, you will have your periods normal. And all. It doesn't mean that you got cured or anything. You are just masking the symptoms. So they will have a problem getting pregnant. We can help. But more importantly, if you lose 5% of your weight, most of the time, 80% of the time, the problem will get solved to a certain level. But always there will be certain needs, and there is no cure for that. It's your genes. So until we find the gene therapy and find these genes and start treating them, you have to live with that. It's not a disease.
All right. Thank you, Doctor, for that wonderful explanation about PCOS and the ovarian cyst. And we do have another question regarding PCOS and fibroids this time. So this question is coming from a 33-year-old woman who has been married for 5 years, and she says that they have no intention to conceive. So she's saying that she got to know that she has PCOS and one fibroid, and she's asking to explain some of the issues that she's currently experiencing. So one of these symptoms was something that you already mentioned about weight gain, and then excessive sweating with body odor, stabbing pain coming from the lower left abdomen and running through the leg, period irregularities, and currently she's also taking Yasmin tablets on and off as well. So to summarize, I think many women experience different kinds of symptoms at the same time when they go through different conditions. So could you please tell us which symptoms that she described are actually related to either of these conditions, that is PCOS or fibroid, and then whether there are any signs among those that she needs to look out for, or whether there's any medical emergency as well. And also, for the benefit of everybody who is watching, can you also tell what Yasmin tablets are given for, and whether it's advisable to just anyhow take it as well?
Right. Okay. It's a good question. So to start off with, continue from the last question. Right. So the treatment is if you want to get regular periods and to have some sort of a control over periods and to reduce certain risk, like if you have polycystic ovarian syndrome, because you're not ovulating, because estrogen is only coming most of the time, there's a risk for endometrial cancer in the future. So by taking a contraceptive pill, which is Yasmin is one of those, and you can reduce most of these effects. So if somebody is diagnosed with polycystic ovarian syndrome, the mainstay of treatment is weight loss and taking a contraceptive pill. And there's another contraceptive pill which contains cryptogyrone acetate, which is also anti-testosterone. So that will reduce their, the cosmetic effects as well. Now, sadly, if somebody have a chance of getting pregnant, that means she's married or is sexually active. The problem with this type of contraceptive pill, though it's called a contraceptive pill, now any woman who's taking contraceptive, if you miss 2 pills, there's a chance of pregnancy. We say about 20%. And when you are using a contraceptive, there's a 1% chance of pregnancy. So if somebody gets pregnant and continue the medicine, let's say this special type of contraceptive, which is called cryptogyrone acetate, that will can cause the baby to be abnormal. And in fact, in other countries, they will advocate termination of pregnancy. So because of that, once somebody is married or, like there's a chance of pregnancy, we can't use it. Now, we usually use it for women who are not married or not sexually active, though it's a contraceptive that is to counteract most of the symptoms associated with polycystic ovarian syndrome. Number one is the hair loss, pimples, and all that will go away, and your periods become regular. You kind of protect your eggs to a certain level, because now when you stop ovulating, the eggs will become dormant, and then when you need it, let's say at 34 years, 35 years, they are there, right? So that's number one. Now this lady who's asking the question, is said that she's taking on and off. Now she has to take it regularly, and especially if she is planning not to have a pregnancy, that is better to take another. And even if you're not married, not having babies, never going to get married, better to have a pill going on, because it reduces a lot of stress risk which they can have in the future. And being a polycystic ovarian syndrome patient, they are high risk for endometrial cancer. So taking a pill for a year or more will reduce endometrial cancer, bowel cancer, and ovarian cancer risk. And period problems are not there. So they will get a period on the dot, less pain. And also, theoretically, they can conserve eggs, basically, because as a woman, any woman, they are born with a set of eggs. And they will ovulate every month. And it's not one egg, it's the cycle, they destroy about a few hundreds of eggs, and only one will become dominant. So by having a contraceptive pill, it's like locking a fridge. And let's say after 4 years, you open the fridge, the same food will be there. Of course, aging happens. So because of aging, the quality goes down. So at least the quantity will be there compared to reducing quality. So those are the facts. And to answer the other question, where the symptoms wise, the weight gain, and now remember, weight gain is not because of polycystic, it's what you're eating, right? Yes, you may eat less, but if you reduce your carbohydrates and eat more proteins and all that, your weight gain will be less. And also you have to do some exercise and all that. Now a lot of a lot of women will do, like they go to parks and go 3-4 rounds with a lot of difficulty and lose about, let's say, 100 kilocalories. And then after that, they go to the paratha shop and eat 2 paratha or have a milkshake and go. But that is 200 calories. But usually they say, doctor, I exercise, but I am not losing weight. And more importantly, they will say, I don't eat, but I gain weight. Right? So important thing is to acknowledge, or, first come to terms. Here I have polycystic ovarian syndrome, or even other women who are gaining weight. Yes, I'm eating, that's why I'm getting weight. It's not because of the pill, because a lot of people don't take the pill because they think it causes weight gain. Now, in Sri Lankan context, a lot of women will start taking the pill after delivery. So they are starting the pill, but they will be eating for 2 people, they will be eating kirikos and all that, but the weight gain is due to this tiny little pill. So this is where, and then they will tell everybody, I took the pill, that's why I gained weight, and others also start believing, but then the actual reason is not that. Now, the only way I can think of getting, weight gain during periods is some women, when during that period time, they have loss of appetite, there are abdominal cramps, they don't eat, they are nauseated. So when you have on a pill, you don't feel most of those symptoms, and you can eat on that week also. That's the only way that you can gain weight. So acknowledge that, right? Now, when you come to fibroids, it's important. Nowadays, we are not too worried about fibroids. We treat or offer treatment only when they cause certain problems. Like number one, if they cause heavy bleeding and we have to assure that it's due to the fibroid, then we have to take it out. That's the commonest reason. Sometimes they have pressure symptoms depending on the size. Some, if it is in the what we call the anterior wall or the top wall of the womb, it falls onto the bladder, and then you feel like always going to the toilet. So that's called one pressure symptom. So then we may think of operating. Or if it is on the posterior wall, which is compressing on the bowel and all that, then have sometimes constipation, back pain and all that, then we have to take it out. But the sheer size of it, let's say it's about more than 5 centimeters, 6 centimeters, we think of operating, not mandated, but we think more likely we tend to operate because we can do it laparoscopically if it is smaller size. So these are the reasons, not like long years ago, where we see a fibroid, we take the womb out, we take the ovaries out. No, now it's a very rare operation to do because these fibroids doesn't change into cancer, or the chance is 1 in a million. So I'm not worried about it that much unless they become symptomatic.
Thank you very much, Professor, for that very elaborative explanation about the symptoms between PCOS as well as fibroid as well. And moving on to our next question. This lady is asking if it is a problem to have period pain without periods, and or sometimes period cramp starts a week before the period. And she's asking whether this is normal and why is it happening. So although this question is only asking about period pain and cramps, I would also like you to ask and explain what sort of common signs or symptoms can occur before period, and whether there are any abnormal signs that women need to be mindful of as well.
That's okay. So first thing is to, when somebody is having periods, there are a few problems. So the normal is if somebody it has to be regular. And the regularity doesn't mean every woman will have a 28-day cycle. From 21 to 35, it's normal, right? So if somebody is having a 21-day cycle, every month she should have a 21-day cycle. Somebody having a 35 days, which is 1.5 months, still they should be having a 1.5 month cycle. It's as long as it's regular, that's fine. But anything more than or less than that is you have to consider there is abnormality. Then a lot of women will bleed for about 3 to 7 days. So more than 7 days or less than 3 days, we are little worried, but less than 3 days, we are not too worried about, but more than 7 days is worried. Then pain, usually a day before or like just soon before the period, they get a little bit of cramps, and even during the period, they have cramps without any disturbance to their, day-to-day activities. They can, let's say they take 2 Panadols, the pain go away, or it's there, but they can do normal day-to-day work, then it's considered normal. Anything beyond that, any pain or anything which disturbs their day-to-day activities, or what we call reduced quality of life, it has to be sorted. There's no other. Now, earlier days, we, like even bleeding, we quantify, right, how much of bleeding, and then we say, you are changing only 4 pads a day, and this is not heavy bleeding, go away. But that woman used to change only 2 pads. Now it's bothering her. Nowadays, we don't say like that. If it bothers you, we treat, or we try to explain that. Sometimes it's just explanation they need. They're just worried about it, and they know, okay, this is a normal variant, that kind of thing. And more importantly, coming back to her question, any pain, now her symptoms can be explained in 2 ways. Number one, whether it's ovulation pain. So some women mid-cycle, we call it, when you have a pain mid-cycle, that indicates somebody's ovulating. That is okay, and that should not be a major pain. And then if she check her temperature afterwards, like the day before, like in a few days before and after, if she feels like, okay, her temperature is going up, it's very likely due to be ovulation. But other more sinister problem is whether it's a symptom of endometriosis. So endometriosis, pain before periods, like really bad pains or severe pain during periods, pain outlasting periods, pain during sexual intercourse, especially with what we call deep penetration, pain going down the legs during periods. When you have periods, when they are passing stools, whether there is constipation, whether there is pain, or whether there is diarrhea, these are all bad symptoms. And when they have period, when they pass urine, either it's painful or it's difficult to distribute, but they feel like there is blood coming through blood stain urine. That's a serious problem. So these are something you have to check immediately. And in a country like ours, where when people bleed like the Mahawali River and have a lot of pain, people are very happy. Right? They say they are suddha venawada, or it's a cleansing process. So that is what we want to get rid of. Right? There's nothing called that. There's no cleansing process. It's just the lining of the womb getting, shred, and it's nothing to do with being clean or not. Right? So always, if you are having heavy periods, especially it affects your hemoglobin level, or it bothers your day-to-day activities, please go and take some advice.
Thank you, Professor, for explaining about period pain and cramps as well, and also busting some myths as well. We do have some comments from our viewers, but I think we can address them as we go along with some of the similar topics that we will be discussing later on. So moving on to our next question, which has been asked in Sinhala. So let's answer that in Sinhala as well. මේ කාන්තාව කියා සිටිනවා කැන්ඩිඩායොසිස් ආසාදන තත්ත්වය ඇතිවීම නිට්ටාවට සුව කළ හැකිද කියලා. ඒ වගේම කියා සිටිනවා තෙවන දරු ප්‍රසූතියෙන් පසුව ඇගේ මේ වන විට ඒ තත්ත්වයට ගොදුරු වෙලා සිටිනවා කියලා. යෝනියට ඇතුළු කරන ඖෂධ භාවිතා කිරීම කළත් නොබෝ දිනකින් නැවතය හටගන්නවා කියලා සඳහන් කරලා තියෙනවා. ඒ වගේම කියනවා සබන් භාවිතයනොත් වැළකීලා සිටිනවා කියලා. නමුත් යෝනිය තදින් කැසීම පවතිනවා කියලා තියෙනවා. ඉතින් අහන්නේ මේ තත්ත්වය සම්බන්ධයෙන් යම්කිසි පැහැදිලි කිරීමක්. ඉතින් මේ පිළිබඳව දැනුවත් කරනකොට වෛද්‍යතුමනි මේ වගේම තවත් සමාන ප්‍රශ්නයක් අපිට ඉංග්‍රීසි වලිනුත් තියෙනවා. අපි ඒක ඊළඟට හමු. ඒක නිසා මේ ප්‍රශ්නයේදී අපිට පැහැදිලි කරලා දෙන්න මේ කැන්ඩිඩායසිස් කියන තත්ත්වය. එතකොට ඒකේ තියෙන රෝග ලක්ෂණ මොනවද කියන එකයි මේ කාන්තාව අහපු ඒ ප්‍රශ්නෙටම අපි පිළිතුරක් සපයමු. ඒක පොඩ්ඩක් පැහැදිලි කරලා දෙන්න. ඊට පස්සේ අපිට පුළුවන් ඒක පාලනය කරගන්න. ඒකට මොනවා හරි වෙන ප්‍රතිකාර ක්‍රම තියෙනවද කියලා සාකච්ඡා කරන්න.
Okay, so අපි ගත්තොත් candidiasis එහෙම නැත්නම් අපි කියනවා අපේ වචනෙන් අපි කියන එක පුස් වර්ගයක් කියලා, right? එතකොට ඒක අපි කියනවා usually අපේ යෝනි මාර්ගයේ තියෙන අපි කියන සාමාන්‍ය ජීවත් වෙන කෙනෙක්. ඒක කිසි හානියක් කරන්නේ නැතුව ඉන්න කෙනෙක්. මොකද අපේ යෝනි මාර්ගයේ ඉන්නවා lactobacillus කියලා තව බැක්ටීරියාවක්. ඒක අපි කියන හොඳ බැක්ටීරියාවක්. ඒකෙන් අපේ යෝනි මාර්ගය කියන්නේ යෝනි මාර්ගයේ ඇසිඩ් වෙලා තියා ගන්නවා. එයා තමයි big boss in the vagina. හරිද? ඊට පස්සේ ඉතින් මේ lactobacillus කියන එක මොන හරි දෙයකට අඩු වුණොත් අපි කියනවා මේ candidiasis කියන මොනවාද පුස් වර්ගයේ වැඩියෙන් grow වෙනවා. එතකොට දැන් කවුරු හරි අපි එතකොට ඒක නිතර එනවා නම් අපි ඒකට ඇයි එහෙම වෙන්නේ කියන ඒතර අපි දැනගන්න ඕනේ යෝනි මාර්ගයේ තියෙන environment එක වෙනස් වෙනවා කියලා. ඒකට ප්‍රධාන හේතු කීපයක් තියෙනවා. පළවෙනි එක තමයි අපි ගත්තොත් අපි ඇන්ටිබයොටික් ගත්තොත් අපි හිතමු අපි කැල්සියම් රිසා වුණාම අපි හරිනම් ඇන්ටිබයොටික් පාවිච්චි කරන්න ඕනේ. හැබැයි ගොඩක් වෙලාවට අපි ලංකාවේ රටවල වෙන දේවල් වළක්වන්න කියලා ඇන්ටිබයොටික් දෙනවා. ඒවයි කරපුවම වෙන්නේ lactobacillus මැරිලා යනවා, candidiasis තියෙනවා. එතකොට ඔන්න candidiasis වැඩි වෙලා ඒගොල්ලන්ට අපි කියනවා මේ සුද යන්න ගන්නවා. හැබැයි දැන් ඉම්පෝර්ටන්ට් එක තමයි මේ යෝනි මාර්ගයෙන් හැමට එනවා. හැමෙන් ආයි යෝනි මාර්ගයෙන්. අපි මොන හරි කොයි වෙලේ හරි ට්‍රීට් කරනකොට යෝනි මාර්ගයට හැමට එක වෙලේම ට්‍රීට් කරන්න. ඒතර අපි ඉස්සෙල්ලාම try කරන්නේ local treatment. ඒ කියන්නේ ඉස්සෙල්ලාම අපි යෝනි මාර්ගයට බෙහෙතක් තියෙනවා දවසට එක රැට එක ගානේ එක්ක දවස් 3යි ඒක සමහර අඩු නම් එක දවසයි 3යි 6යි කොහොම තියෙනවා. ඒතර ගොඩාක් තියෙනවා අපි දවස් 6ක් දානවා. ඒ වගේම අපි එක පළවෙනි පාර එකක් දානවා. ඊට පස්සේ ආයෙ පාරක් අවුත් 3 දානවා. ඊට පස්සේ නිතර යනවා 6 දානවා. ඒ වගේ කරනවා. හැබැයි ඒ දාන හැම වෙලේම ඒගොල්ලෝ යෝනි මාර්ගයේ આવටත් ඒ ක්‍රීම් එක ගන්න ඕනේ. හැබැයි ක්‍රීම් එක අපි උදේට හවසට සති දෙකක්වත් ගන්න ඕන අඩු මේක ඇරලා. ඒ පළවෙනි එක අපි ට්‍රීට් කරනවා දෙකටම කරනවා. ඊට පස්සේ ඇයි මෙහෙම වෙන්නේ කියන එක හොයන්න ඕනේ. එකක් තමයි අපි බලන්න ඕනේ ඒ කාර හරි තියෙන කෙනෙකුට දිය වැඩියාව, තයිරොයිඩ් වගේ මොන හරි ඒ කියන්නේ ඒගොල්ලන්ගේ අපි කියන ප්‍රතිශක්තිකරණය අඩු වෙන දෙයක් වෙලා තියෙනවා කියලා. දිය වැඩියාව සහ තයිරොයිඩ් ප්‍රශ්න තමයි common ඒවා. ඒ වගේම ඇන්ටිබයොටික් භාවිතය. ඒ වගේම සමහරවිට මේක අපි කියනවා අපි දැන් මේ අර හෙම්බ්‍රිස්සාව කැස්ස වගේ අපේ කියන්නේ මේ අපි දැන් ඩස්ට් එක ගියාම කිව්මුන් යනවා වගේ. ඒතර අපි ගියාම අපිට නාය හොට්ටු ඇවිල්ලා එහෙම වෙනවා. අන්න ඒ වගේ මොකක් හරි වෙලා අපි කියනවා මේ ඒගොල්ලන්ගේ යෝනි මාර්ගයේ තියෙන මේ මොනවාද environment එක වෙනස් වෙලා. ඒ කියන්නේ allergic reaction එකක් වගේ එනවා. ඒක තමන්ගේ මොනවාද අපි හිතමු දැන් අපි සමහරට කියනවා දිතර වෙනවා cotton underwear ගැන. මොකද සමහරට synthetic underwears වල ඒගොල්ලෝ allergic එකක් වෙන්න පුළුවන්. panty liners ඉඳ වෙන්න පුළුවන්. සමහරලාට ඒගොල්ලන්ගේ අපි කියමු sanitary towels ඉඳ. ඒක ඒ pads જાතිය සමහරට එක pad එකකට එන්නේ අනිත් pad එකට එන්න පුළුවන්. එහෙම වෙන්න පුළුවන්. සමහර අය tampons ඒ වගේ තියෙන දේවල් වල allergic reaction එකක් වෙන්න පුළුවන්. සමහරට ගාන soap જાතියක් වෙන්න පුළුවන්. shampoo જાතියක් වෙන. මොකද ඒකට ගානකට ඒක මත තියන්න මේක අපි උඩින් ආපුවමත් shampoo එකක් ගන්න. ඒතර සමහරට අපි බලන්න ඕනේ නිතර දැන් අපි මොන හරි දෙයක් වෙනස් කරාට පස්සේ මේක එන්නේ. තමන්ගේ එක මොකක්ද කියන එක හොයාගන්න ඕනේ. ඒතර අපි ඒ වගේම සමහර තියෙනවා අපි ලංකාවේ common නැති වුණාට අපි කියනවා vaginal douching කියලා. ඒ කියන්නේ ඒගොල්ලෝ වැජයින එකට සෙන්ට් අරන් මනන් දානවා. ඒතකොට මේ සමහර කට්ටිය එහෙම වුණාම ඔන්න ඒක ප්‍රශ්නයක් වෙනවා. ඒකට තියෙනවා ඉතින් සමහරලාට ඔකට අපි ට්‍රීට්මන්ට් ඒවා දෙනවා. ඊළඟට අපි කියනවා මේ කමෙන්ට්ස් මේ ප්‍රෝබයොටික්ස්. ඒ කියන්නේ දැන් අපිට බැක්ටීරියා නැත්තම් බැක්ටීරියාවේ රෝපණය කළොත් හරියනවනේ. අන්න ඒ වගේ ප්‍රෝබයොටික්ස් කියන්නේ එහෙම හදපු බැක්ටීරියා තියෙනවා. ඒවා දෙන්න පුළුවන්. ඊළඟට යෝනි මාර්ගයේ pH එක අඩු වෙන හේතුවක් වුණාමත් ලැක්ටෝබැසිලස් අඩු වෙලා. මොකද ලැක්ටෝබැසිලස් වැඩෙන්නේ pH එක වැඩි වුණා. අඩු වුණාම. ඒ කියන්නේ ඇසිඩික් වුණා. ඒතර මොන හටට බාස්මික වුණාමත් ඒක වෙන. ඒකට අපි ඒකට සබන් ගොඩක් නිතර පාවිච්චි කරනවා නේ වෙනවා. ඒ වගේම තවත් වෙලාවට අපේ ලංකාවේ අපි දකින එකක් තමයි මේ කැන්ඩිඩයිසිස් වැඩි වෙන හේතුව තමයි වැඩි පිරිසුදුකම කියන එක. අපි යනවා টয়ලට් යන හැම වෙලේම හොදනවා. ඊට පස්සේ හොදලා හැබැයි ඉතින් පිහදාන්නේ නැහැ. මොකද අපි කියන්නේ ටිෂුස් පාවිච්චි කරන එක නම් විශේෂයෙන් ඒව නැහැ. එතකොට ඔන්න එනවා වතුර වගේ තියෙනවා නිතර තෙතම දෙන දිනොත් අපි දන්නවා අපි පාන් කෑල්ලක් තියලා වතුර දාපු පාන් කෑල්ලක වේලිච්ච පාන් කෑල්ල කොයි එකද පුස්කන්න ඉක්මනින් කියන එක අපි දන්නවා. ඒ වගේ වැඩි පිරිසුදුකම් වුණාමත් සමහරවිට මේ කැන්ඩිඩයිසිස් වෙන chance එක වැඩි වෙනවා. ඊට පස්සේ ඒ බලන්න ඕනේ යා දැන් අපි හිතමුකෝ දැන් sexual active එක කියන ඔන්න කැන්ඩිඩයිසිස් වෙනවා. අපි sexual active වෙලා ටික කාලයක් කරලා ඊට පස්සේ එකපාර නැවැත්තුවොත් හරි එහෙම කාලයක් නවත්තනකොට ටිකක් ඒක එන්න ගන්න මොකද අර environment එක වෙනස් වෙලා තියෙන හින්දා කාලයක්. ඉතින් අපි ඉතින් විහිළුවට කියන පුස් කන්න දෙන්න එපා කියලා. හරිද? ඒ වගේ ඉතින් අපි අර එක ඒ කියන්නේ අපි සමහරවිට ඒක වෙනවා. ඒ වගේම අනිත් පැත්තටත් වෙනවා. ඒ කියන්නේ කාගේ හරි යෝනි මාර්ගයේ ඒ කියන්නේ ඒ කැන්ඩයිසිස් තිබ්බට පස්සේ අපි තමු එකතු වුණාට පස්සේ ඒක පාර්ට්නර්ට යනවා. ඒතර පාර්ට්නර්ට ගියාම ඒක පිරිමින්ට ඒක ගොඩක් අයට කිසිම ලක්ෂණයක් නැහැ. ඒතර ආයේ දැන් එයා කියව වුණාට පස්සේ ආයෙ එකතු වෙනකොට ආයෙ එනවා. ඉතින් ඒ වගේ නිතර ණයට අපි කියන්නේ එතකොට එකපාර දවස් 6 ට්‍රීට්මන්ට් එක අරගෙන ඒත් එක්කම ක්‍රීම් එකත් උදේටයි රැටයි සති දෙකක් ගාලා හස්බන්ඩ්ටත් නැත්නම් පාර්ට්නර්ටත් ඒගොල්ලෝගේ මේ ශිෂ්නේ ඒක සති දෙකක් ගන්න කියලා. හැබැයි සති දෙකේ සෙක්ස් කරන්න නැතුව ඉන්න කියලා. ඊට පස්සේ આવොත් බලන්න. ඒකත් හරියට අපි සෙකන්ඩ් ලයින් යනවා. ඉතින් සෙකන්ඩ් ලයින් යන්නේ බෙහෙත් බොන්න වෙනවා. ඉතින් ඒක බෙහෙත සතියකට සැරේ වගේ නිකන් ගොඩාක් කල් බොන්න වෙනවා. මාස 2-3 බොන්න වෙනවා. සතිය දෙක ගාන. හැබැයි ඉතින් කවුරු හරි එක්කෙනෙක් බබෙක් හදන්න බලාපොරොත්තු වෙනවා. ඒ වගේ කාලෙදී ඒ අපි කියන ඇන්ටි ෆංගල්ස් බොන්න බෑ. ඉතින් ඒ හින්දා තමයි අපි චුට්ටක් ඒක දෙන්න අපි සෙකන්ඩ් ලයින් තර්ඩ් ලයින් වුණාම තමයි කියන්නේ අනිත් ඒවා try කරලා බැරි වුණාම තමයි කැන්ඩයිසිස් වලට ඕරල් ට්‍රීට්මන්ට් එකක් තියෙනවා. ඒක ටික ප්‍රොලොංග් කෝස් එකක් දෙන්න පුළුවන්.
හොඳයි බොහොම ස්තුතියි වෛද්‍යතුමනි මේ පැහැදිලි කිරීමට. ඒකදී මම හිතන්නේ අපි ඊළඟට තියෙන ප්‍රශ්නයත් ඕකම තමයි ඉංග්‍රීසි වලින්. මම හිතන්නේ ඒකට අදාළවත් ඔබ මේ වෙලේ පිළිතුරු සැපියු. නමුත් අපි ඉක්මනින්ම කෙටියෙන් ඉංග්‍රීසි වලිනුත් ඒකට පිළිතුරු දෙමු. අහලා තියෙන්නේ Doctor, 5 years ago, during my pregnancy scan, it was noted that I had vaginal candidiasis. And during a pap test as well, MOH doctors also identified the same issue and prescribed medication, but it has not been fully cured. And she still experiences daily discharge, which is causing her stress. And she's asking, what should she do? So you already explained, but I think briefly explain in English once again as well.
Right. Okay. So as I tell, candidiasis is a very common problem. Right, and a lot of women suffer from that. And important thing is you have to find the cause why candidiasis is happening. So whether it's something to do with what we call abuse of antibiotics, or whether there's reduction in immunity, so I have to check for diabetes and thyroid problems. And maybe if she's taking any immunosuppressants like steroids and other immunosuppressant medication like CQs and things like that, they can have methotrexate. For rheumatoid arthritis, they tend to have increased risk.
Professor, are you still there? I think our professor's internet connection has been broken for a while. We will be back shortly. Just apologize for the short interruption.
Of having candidiasis.
Professor, are you still there? Because your connection got stuck and we can't hear you at all. All right, welcome back, Professor. Yeah, so you got basically disconnected while you were explaining that answer. In 2 minutes, if you can quickly answer about the same question. Can you hear?
What is that?
Can you hear us, Doctor?
Can you hear me?
Yeah. We can hear you. Can you hear us?
Hello?
Yeah, we can hear you, Doctor. Okay, just to our viewers, I think we will try to reconnect with our doctor and we'll be back shortly once again. Welcome back, Professor. Extremely.
Hello.
Can you hear us, Professor? Okay.
Hello.
Can you hear us, Professor?
Yes. Yeah. Sorry.
Okay. We just have to apologize extremely. Sorry for the inconvenience. Sometimes with technology, it's not easy to do a live stream. So we were talking about the candidiasis question that you were explaining it in single. So maybe in 1 minute, just quickly explain in English as well. She was asking what should she do if she has discharge, daily discharge, even after medication.
Yeah, so she has to find out what's the reason for the dish, in the sense whether it's actually candidiasis, that's a number, because sometimes it can be a normal discharge. That's number one. If it's candidiasis, it's better to take a swab and see whether the medication that she's been prescribed is not resistant for that candidiasis which being treated, and also whether there's a recurrence, whether she has got it again, whether, as I told you, the soap, the shampoos, the panty liners, the what do you call, the underwears, and she has to find a reason, because or had to check for immunity issues like thyroid, sugars, the diabetes levels, and all that. And if all those are there, she may worthwhile taking a oral treatment, and that has to be prescribed. It's a long treatment that we had to discuss and start.
All right. Thank you very much, Professor. Moving on to our next question. This is a very delicate topic, one that many women, when trying to conceive, may sadly experience, that is miscarriages. And you have extensively spoken about miscarriages through our Facebook page and various other channels as well. But let's briefly answer this question as well. So this lady is saying that she has experienced 2 miscarriages so far. And so she's asking, should she undergo testing now or wait until after a 3rd miscarriage? And I sincerely hope there won't be a 3rd miscarriage for her. But I think what she wants to know about recurrent miscarriages and when to get tested as well.
Right. So it's depends on the country. Now, for instance, in you look at the American guidelines, they will start testing from 2 miscarriages. But in Sri Lanka, we and the UK, we wait for 3 miscarriages. The main reason is anybody getting pregnant, there is a 20% chance of miscarriage, and that is nothing to do with what we or the couple do or don't do. It's the day of conception, there is a anomaly, what we call a chromosome anomaly, which is usually not compatible with life, and that is the reason for most of the miscarriages. So that's number one. And especially if the miscarriage happens before seeing the heartbeat or before 8 weeks, even seeing the heartbeat before 8 weeks, it's usually, or 99% is due to a chromosome anomaly, and you don't need to do any testing. However, any miscarriage, even one after 10 weeks or at any time, like before 24 weeks, we call miscarriage. From 10 to 24 weeks, any miscarriage, or we call, you have to test. There's a heap of tests to be done, and then only you plan the pregnancy and go ahead with it. But otherwise, if it's only, so I mean, each miscarriage is very important. Like for anybody who's going through a miscarriage, regardless of what we say, they have lost their kids or their children. So, but important thing is to not to feel guilty about it. It's nothing to do with whether you climb stairs or go on buses or bicycles or eat certain food. It's the day of conception. Nothing can be done about that. And any woman getting, and it doesn't mean if you had 5 miscarriages and the 6th pregnancy, still you have a 20% chance of miscarriage. And somebody had 5 normal deliveries without any issue, and if she gets pregnant the 6th time, there is a increased risk of 20% chance of miscarriage only. It doesn't increase nor decrease. The only thing is, if somebody is above 35 or the age, with age having chromosome anomalies increases. That's why you are seeing miscarriages at an old age group common than a young age group. Okay.
All right. Thank you, doctor. On that topic itself, I just want to know whether any male factors could also contribute to recurrent miscarriages.
Yes, because they had to do a genetic testing in that case, right? So we call it, there are certain X chromosome related or Y chromosome related problems. We have identified some mitochondrial issues and all that. But that's again, as I told you, once we come to 3 miscarriage or that, we do a heap of tests, and which includes those as well.
All right. Thank you very much, doctor. Okay, thank you, Professor, for explaining about recurrent miscarriages. There was a question from one of our viewers. We'll quickly take that as well because it's relevant this area. So she's saying, Professor, can you briefly explain about placenta accreta and how important it is to consult with a specialist who has experience to help manage pregnancy and the importance of planning the delivery? So if you can quickly answer that question as well. Thank you.
Can you repeat that again, please?
Yes. Professor, can you briefly explain about placenta accreta and how important it is to consult with a specialist who has experience to help manage the pregnancy and the importance of planning the delivery?
Right. Okay. So it's a very good question. And actually, when somebody is having what we call placenta accreta, right, it's a serious condition. It's what it means is if somebody has seen a cesarean section before, or any like sometimes any procedures in the womb, the placenta has, like usually placenta has a layer in between the uterine muscles and the placenta. There is a what we call it, there's a kind of a protective barrier. Now, for some reason, especially when there's a cesarean section, that barrier is already lost, and if the placenta get attached near that scar, it starts growing, and it's keep on growing, and it comes out from the uterine muscles and go to the bladder and adjacent structures. It can be go to the bowel, or depends on where the cut and the placenta is. And usually, because of cesarean section, we see it high, and usually it's anterior placenta previa, we call it, which is in the top wall. Now, if that happens, you have to be, once it's diagnosed, you have to deliver it in a specialized center. Wherever in Sri Lanka or wherever in the world, there are specific centers to treat. So in Colombo, there is what we call Disoisa Maternity Hospital, and what we call the Professor Unit Colombo has been taking care of placenta accreta for the whole country. And recently, Colombo South Teaching Hospital has joined, and few other centers, one in Kandy and all that, like that. Usually, they are transferred to that specialized units, and from usually 34 weeks to somewhere they'll be in the hospital, and usually we deliver them around 36 weeks before she goes into labor, in a very controlled environment with ICU and facilities for what we call rapid blood transfusion and all that. So usually most of the women will have a hysterectomy, or we take the baby out and we remove the womb as well, because we can't protect it. But nowadays sometimes we try to cut part of the placenta attached part and then try to conserve the uterus, and in most cases they can't still go for a pregnancy again, but we do it because the morbidity wise, in the sense, doing a hysterectomy or taking the womb out is much more complicated surgery than taking the fat part out. But depending on the patient to patient, at the time of surgery, we decide that.
All right, thank you very much, doctor. I hope the viewer got a very elaborative response from you. Now, moving on to one of our next questions. This is related to birth control options. Again, a topic that you have in detail described in one of our What Matters to Her episodes as well. So she's asking, she's saying that she already has one child and she is not planning to have another. So she's asking if the copper IUD is an effective form of contraception. What are its costs and possible side effects as well? So while explaining, please also let us know whether there are these free services available in government hospitals or any other women health clinics in Sri Lanka. And also she is mentioning effective. So how does a woman know which contraceptive method is effective for them?
Right. So I'll give a broad answer, as I would have if she comes to me to discuss, because choosing a contraceptive is like going to a buffet. So there should be many options, and each woman should choose what is best suits her, not what is offered to her, right? Now in Sri Lanka we have only 7 methods. In the UK and in America and all these developed countries, they have about 15 methods. So you have to choose, and ideally you should go through each and every method, discuss the advantages and disadvantages and side effects, and depending on their medical and other history, they can choose the best which suits her. Now let's talk about this effectiveness. Now we have what we call barrier methods, which is condoms. We have natural methods, which is the billing methods, or we protect during these days and all that. And then we have the contraceptive pill and the copper IUCD. And there's something called levonorgestrel releasing IUS, which is LNG IUS systems. And there is implant, which goes underarm. And also we have the injections called DMPA. Right? Those are the 7 methods available in Sri Lanka. So we talk about a failure rate. Now, when you have 15 methods or 7 methods, one has to understand there's no ideal contraception, right? So ideal contraception should be, not user dependent, protect 100%, and no side effects, no disadvantages like that. But depending on the method chose, that we first of all talk about a failure rate. If somebody have sex naturally, without any protection, each year they have an 80% chance of pregnancy. Now we call it a failure rate. So in condoms and what we call our barrier methods or the natural methods, their failure rate can be up to 5 to 26%. It can be high as 26% if not properly used. The pill, which is 1%. And then you have what we call these other methods. We call them long-acting reversible contraception and fit and forget devices. So basically, they are like the moment they are used, they can't get pregnant. The moment they are taken out, they can get pregnant, and it's not user dependent, right? So copper IUCD, one of those, and the chance of pregnancy is 1 in 1,000, whereas the levonorgestrel releasing system 1 in 2,000. So that's the best available. But however, there are certain things. Now, for instance, whether you like hormones or not. Now, pill and the levonorgestrel and the implants are hormonal contraceptive. So it has some effect on their periods. For instance, levonorgestrel IUS releasing system patients will have 70% will have no periods for 5 years. In the developed world or in other countries, that's one of the most sought after, because you don't have periods, you have more freedom. But again, as I told you earlier, in Sri Lanka, if you use and no periods, if they don't again bleed like the Mahal relay, they think that's no cleansing happening, and they got really, really alarmed when they don't have periods, right? So you have to know that. Now, what you call levonorgestrel, what you call the copper IUCD, it's not no hormonal. It stays inside the womb, and it works there. It stays there for 10 years. So when it comes to cost-effective, this is the best, right? And it's offered free of charge from the government sector in any of the MOHs, or you can go to any hospital or any family planning association, in Colombo and all that. They do it free of charge, right? And also, even if they are doing in the private sector, the cost is very low compared to all the other methods, right? So one has to choose what is best for her. The only the disadvantages are some womb doesn't like anything inside, about 5%. So 95% are happy, but 5% either they have irregular periods, pain, or discharges. We have to take it out. And apart from condoms, none of the methods will protect you from a sexually transmitted disease. So we always advise, if you are like not contraception wise, it's there. Now, for instance, especially copper IUCD, if somebody is having casual sex and all that, that can be an issue. So protection is always from the STI is only from a barrier method like condom. So that is the important things. And so sometimes with the copper IUCD, they can have heavy periods. So again, that's an indication if it is too much to remove it. And most of these are described that they migrate, where when you're trying to put the copper IUCD, it can go to the bowel and all that. But I believe it happens at the time of insertion. So once you put it, if you do a scan and see whether it's in the correct place, the chance of that happening is very, very low.
All right, thank you very much, Doctor, for that detailed explanation. And if anybody wants to further look into that topic, we have done our 20th episode in What Matters to Her series, and you can watch it in our Facebook page as well. So, moving on to our next question, because we do have a couple of questions and time is running. So, this question is sent by a 33-year-old lady. She says she had her first child in 2021 via a vaginal delivery, and the first 2 days postpartum, she was feeling well, but starting on the third day onwards, she had experienced continuous pain similar to labor pains that lasted until the 13th day. And on 13th day, a piece of placenta about the size of a tennis ball had passed at home while she was standing, accompanied by severe labor-like pain. So she's saying whether she's unsure whether this is a normal condition, and although it has been a couple of years, she's now fearful to conceive again, although she wishes to have a second child as well. So can you please explain, is this something common, that retained placenta, and what could be the cause, and who is at higher risk?
Right. So I'm sorry to hear what has happened to her, but definitely there are a few things, right? Number one, now, first of all, sometimes when you see, unless we have a histological evidence that it's the placenta, sometimes organized blood clot can looks like a placenta because it's become very, very fibrous, and over the period of time, it becomes like a big ball, or like it takes the shape of the womb. So number one is whether it's actually the placenta. That's number one. And if it is the placenta, so because most of the time, some, like we have seen that they come with when they are scared and they have passed a clot and all that. That's usually it's a blood clot, because you have to remember the womb. Sometimes the neck of the womb get constricted soon after delivery, and especially with the medicine that we give, and blood collected, and then they become a clot, and then they later they organize themselves and they become a big, very hard kind of a mass, and they can come. And especially if it is long, and it sometimes get calcium deposits, so it's even harder. So that's number one, to see. So if it is gone under the microscope and check whether it's a placental tissue, it's difficult to say, but okay, let's assume. If it is assuming that it's a placenta, there are a few reasons. Number one, okay, sometimes when, especially for normal delivery, we look at the placenta and we look at whether there are any missing parts. So we usually don't scan afterwards. So we look at the placenta, and if a part is missing, then we know, okay, there's a problem. So then we go. But if at the time of the delivery, usually the person who did the delivery say, okay, the placenta has come completely, then we say, okay, it's okay. But then sometimes there can be a part of the placenta missing, even if we say that. The other thing is there's something called very, very rare phenomenon called succinate lobe, where there's a small another part of the placenta. It's like two satellites. So the big placenta comes and that part comes out, and we don't know because we look at it, we see the complete placenta, we go, but that part is already there. And sometimes with time it comes out. Sometimes there is what we call, if there's a manual removal, that is the placenta adhered, and at the time of delivery it didn't come, then we take it out manually. We put our hands in and we separate and take. Sometimes the part will be there, even though we try to get it. And usually that happens, before they are discharged, we do a scan and see. And if it is there, then we go. And in certain instances, we actually leave it deliberately. And we know that there is a placenta, and sometimes in certain placenta accretas or certain there where we think, okay, we can leave it, because as I told you, we have to remove the placenta, the womb sometimes if adhered abnormally. So sometimes we leave it, and we usually tell the woman here, this part is there, because sometimes naturally it separates very slowly, and after about month to 2 months, it comes out naturally. So then that less bleeding, and we are more in control. So those are the reasons, and so either deliberate or without knowing. And of course, sometimes it can. So for her, my advice is chance of that happening is very, very low. So I know it's a traumatic experience, but like especially after delivery, now the chance is after delivery. So once before delivery, she has to make sure that she do a scan and see everything is okay, and then maybe after when she comes for the 1 week or 2 weeks review, again do a scan and see whether the womb is clear, then she doesn't have to worry about it.
But Doctor, I think this happened a couple of years ago. So what can she do to prepare for the next pregnancy? I mean,
if she gets periods regularly and without any issues, then she can start trying for a baby. Now, only thing is, okay, theoretically, there's a risk, okay, if it got infected and all that, the tubes may got blocked, let's say theoretically. So if she try for about, let's say, 3 to 6 months, she's not conceiving, she can check the tubes. If the tubes are also okay by, we have different method of checking tubes, patency. If it is okay, then she knows it's nothing to do with what happened to her before.
All right. Thank you very much, Doctor, for shedding light on retained placenta. Now, moving on to our next question. This lady says that she's 3 months postpartum and occasionally feel a burning sensation around her C-section scar, and she's asking if this is normal. Also, quickly explain what are some of the steps that women should take care of immediately after a C-section to ensure that there's a smooth recovery with the injury as well.
Right. Okay. So this burning sensation is actually due to nerve entrapment or nerve issues. Now you have to remember, we do a cesarean section. Like if it is done for, maternal in the sense, no reason, right? We saw it without any medical reason. You have to remember, though it's a safe procedure nowadays, still it's a major surgery. And also long years ago, we used to cut this way, like what we call midline. Now we cut it this way just for cosmetic reason, nothing else. By cutting this way, because all the nerves goes like in the body goes from here to here, like this way, right? So when we cut that, we cut through the nerves, and we cut lower because the nerve are less there, but still, depending on as I told you, from person to person, there can be more nerves in the superficial layers where some have deeper and some has less nerves. So if we cut through the nerves, then the damage to nerves are usually permanent. But the good news is sometimes when we cut in the cesarean section horizontally, some nerves will regrow slowly, but usually it's so sometimes just above the scar, you have hypersensitivity, that is, they have more sensation, and below the scar, sometimes no sensation, it's just only numb feeling. You can even put a needle through that place, nothing will that woman can feel. So that's a when you embark, like especially if you are doing it for non-medical reason, you have to remember that. That's number one, that it can happen. Number two is that looking after, like soon after delivery, remember, because a lot of people think it's a normal delivery. It's not. It's though she feel better the following day. Now we also try to treat it this like a very normal thing to happen, because it's very safe nowadays. But there are ways of getting on and getting down, like how to get down, because though we are worried about the skin scar, actually it's nothing to do with the skin scar. Underneath there is something called rectus. If it doesn't heal properly, there can be hernias. Now you have to remember, like somebody we cut like this, like here, and then we suture it like this. If somebody goes like this all the time, this tears and there'll be opening like that, and then the bowel and things can come out. We call it a hernia, right? So now if you want further advice on what to do after cesarean section, we have a video through 9 wells, which is called 9 wells part 1, so easy to remember, and part 2, like within first 24 hours and after going home for 2 weeks, what should be done and should not be done, it's there. So especially how to get on and get on to the bed, but depending on the person and their it's my way of doing it. It doesn't mean that others has to do the same way. So you have to remember that each individual has the surgeon has their variation, so you have to remember that. But apart from that, that will give you some idea about what to do after delivery.
All right. Thank you very much, Professor, for elaborating on C-section scar recovery. And you can watch that 9 wells videos on their page as well. So moving on to our next question, one of your favorite topics, I think. This lady says she is a breastfeeding mother with a 3-month-old baby and has noticed a decrease in her sexual desire. So she wants to know if this is normal experience after childbirth. So could you please explain when a woman can generally expect her sexual desire to return soon after giving childbirth as well?
Right. So that's okay. So it's first of all, you have to know why somebody has less sexual feelings. Now, after childbirth, it's a common thing, because you just had a delivery, your body image has changed, and you're breastfeeding somebody, and then you can't sleep every 2 hours, 3 hours, maybe wakes up and you are very tired, and then you don't have like so, and in the natural circumstances, because the when we were in the jungle, I always say that the idea is to, when you're breastfeeding, you have to conserve energy, and that woman should not get pregnant. So the what you call there are two natural phenomena happening. Number one is breastfeeding itself is a contraceptive. So if you're exclusive breastfeeding, the chance of pregnancy for 6 months is only 2%, right? That's number one. Number two is actually the desires goes down, so that somebody is not engaged in sexual intercourse, so that the pregnancy is prevented in natural world. Now in the modern world, so you have to remember, like now there is a part as a woman she has to play, and as there's a part as a man that other person has to play. Now when the childbirth happens, and nowadays we don't have a lot of help from the extended family. Mother comes sometimes, but in, like, let's say you are in another country and all that, nobody's there to help you. You have to look after, right? So now when we are in our culture, we think, okay, the man will come home, sleep, and do all the other things, and then the baby is looked after by the woman only, and also even the cooking and things are done by. So then she's going to be tired, and no, the man only comes for that part. It's not going to work. So it has to be a both-way phenomenon. So with that, and you had to kind of win, and also, of course, because we are humans and we are the only species, maybe dolphins, apart from that, have sex for fun. All the other animals have sex for reproduction, right? So and as men, and the other thing is that now the both parties has to understand, number one, as a man, like if I take a simple thing, for men, sex is like food for most majority, right? They have to have it, let's say, every day or something like that. But for women, sex is like a dessert. Some, whether you have it or not, it doesn't matter. Some, of course, have to have dessert every day. Some doesn't want to have it, like, it doesn't matter, right? So that's basically, so you have to come to a agreement, because then there'll be a lot of what we call stress between the relationship, because there is a man who wants it and there's a woman who doesn't want it. So there can be a problem. So, but as humans, we have more intellectual power, so we can come across, we can counteract our other normal desires. So somebody who's really want to have sex can say, okay, I don't want it every day, something like that. And the woman, even though they say sexual desires, then you can say, okay, as a man, that person wants it, then we will try to come to a middle ground. Now, the important thing is when you look at sex, right? So in all biology world, right, including humans, anybody, we are very, very selfish, right, usually, right? So we don't want anybody to be happy. Now, let's say there's a animal whose leg is broken. Nobody's going to feed that animal. That animal is going to die. And the other animals who are eating will, if somebody's hungry, still nobody's going to give the other animal food. So similarly, even in the humans, it's the same. We had earlier days alpha male, and even in the modern world also, we don't like anybody to be happy, right? But sex is the only time where you actually be happy by looking at somebody being happy. So that has to be, manipulated. So you are doing things not only for yourself, for somebody else. So it's a very, sometimes a selfless act. That's why it's called making love, right? Of course, it can happen in different way, but you have to remember, both parties has to play an active role in that. Now, to answer a question, yes, it's true that it goes down. Yes, it's true, but you have to kind of see whether it's only that, right? Because breastfeeding, because whether both of parties take responsibility, and then of course you have to make an effort also, right? So I usually say, if you have time to eat, you should have time to have sex, right? Yes.
Okay, thank you very much, Doctor, for nicely explaining a concern that is on the minds of many new mothers, I think, and if not well understood, it can have a significant impact on marital life as well.
Just to add one more thing, Karuka, just to add to one more thing for that.
Yes.
Thing, right? So usually we advocate, whether it's cesarean section or vaginal delivery, wait till 6 weeks to start sexual act again. right? Because the
Thank
body
you.
becomes somewhat normal. Yeah.
Yes, thank you for that important tip as well. All right, so moving on to our next couple of questions. Some are related to the comments that we have received by our viewers as well. So I will try to gather them together as well because we are running out of time too. So this lady is saying that she has had a C-section delivery 2 years ago, and since then her periods have not returned. So she is currently breastfeeding as well, and she wants to know if this is normal. And we do have some comments from the live viewers as well regarding that. So one person is asking, yeah, she's also saying that her period has not started and whether it's normal as well. And we do have another question in singular asking a similar thing about treatment. So yeah, up to you, doctor.
Right. Yeah. So again, as I told you, breastfeeding is a natural contraceptive, and now some usually for 6 months not having period is normal, but some women, if you are continuing, because it's about prolactin. Now, for women who let's say was subfertile, when we do the initial workup, we check the prolactin level. Sometimes it's slightly high, they will not have periods or they will be ovulating. So similarly, if you're exclusively breastfeeding, or even after 6 months you start thing and you are breastfeeding, there is a high risk. There's a chance that until you stop breastfeeding, the period will not happen, right? So that's a normal phenomenon. But if she's like 2 years and all that, we can give some medicine to start the period and see whether it comes again. Again, starting a contraceptive after 6 months, after being the baby will help you with the periods, because they will come then naturally every 28 days and like that, right? But it's not mandatory, so you have to remember. But if you don't get period, you have to always remember every month you have to check your urine, just to check whether you got pregnant in between without knowing. Many instances it has happened.
So that means even if you don't get your period, you still can get pregnant during that.
Yes.
When you're breastfeeding. All right. Okay. So the singular question is, so මේ කාන්තාව කියා සිටින අය වයස 33ක එක්දරු මවක් කියලා. දරුවා පිළිසිඳ ගන්නත් පෙර සිටම ඇගේ ඔසප් චක්‍රය අක්‍රමවත් වෙලා තිබෙනවා. ඒ වගේම දරුවා පිළිසිඳ ගන්නත් ඩිම්බ මෝරණ බෙහෙත් භාවිතා කරලා තියෙනවා. හැබැයි ස්වභාවික තමයි පිළිසිඳගෙන තියෙන්නේ. ප්‍රසූතියෙන් පසු මුල් දින කීපය තුල රුධිරය පිට වුණත් ඊට පස්සේ ඒක නැවතලා තියෙනවා. ඒ සිසේරියන් සැත්කමක් හැල්ලා තියෙන්නේ. ඉතින් දැන් ඇයටත් අවුරුදු 1කමාරක් කලින් එක්කෙනා අවුරුදු 2ක් කිව්වා. මෙයාට 1කමාරකුත් ගිහිල්ලා තාමත් ඔසප් වීම සිදු වෙලා නැහැ. ඒ වෙනුවෙන් බෙහෙත් ගන්න ඕනේද කියලා තමයි අහන්නේ. අපි කලින් එකේ සාකච්ඡා කරේ ඒ කියන්නේ ඒක වෙනවද එහෙම නෝමල්ද කියන එක නිසා. දැන් මේකෙදි අපි සාකච්ඡා කරමු ඉක්මනට මේ වගේ කෙනෙකුට තියෙන ප්‍රතිකාර ක්‍රම මොනවද කියන එක සම්බන්ධයෙන්.
ඉතින් ඇස් මං කිව්වා ඉතින් very likely යට polycystic හරි ඒ වල කියන්නේ ඩිම්බ මෝරණේ ප්‍රශ්නයක් තියෙනවා. ඉතින් ඩිම්බ මෝරණ නැත්තම් period වෙන්නේ නැති විශේෂ වේල පහෙන් දීලා උදව් කළා නම් බබෙක් හැදුවේ අනිවාර්යයෙන්ම after delivery එයා කියන්නේ වෙන contraindications නැත්නම් උපත් පාලන පෙති ගත්තොත් ඒ ටික වෙයි. ඉතින් යාට උපත් පාලන පෙති එක දිගටම ගන්න පටන් ගත්තොත් දවස් 21යි දවස් 7යි දිගට යනකොට ඔන්න දවස් 7 කාලයක් ගියාම period හැදෙන්න ගනි. ඒක කිරීම ගොඩාක් වැදගත් වෙනවා මේ වගේ කෙනෙක් අනිත් අයට වඩා.
හොඳයි බොහොම ස්තුතියි වෛද්‍යතුමනි. අපි තවත් ප්‍රශ්නයකට මේ අපේ එවපු එකකට යමු වෙමු. So it has been asked in English, how long does vaginal bleeding last after a C-section? I'm 1.5 months postpartum and I'm still having bleeding. Is that normal? She's asking.
Right. Usually, in the first 3 weeks, the bleeding should stop. Right. So the bleeding should be less and less, and then the color changes and it becomes colorless and it stops. Now, younger you are, there's a chance that you have recommenced your period. So if you had an initial period of no periods, and then let's say after about 1 month or 1.5 months, you start bleeding again, that's their period. And sometimes the period can be very chaotic. Sometimes you have it, and sometimes it comes back in 2 weeks time like that. That's normal. But continuously bleeding more than 4 weeks, she has to check.
All right. Thank you, Professor, for that question as well. And moving on to our next questions. So this lady is saying that she had a vaginal delivery about a year ago. In certain months, she observes spotting just right in the middle of her menstrual cycle. So she's asking if this mid-cycle spotting is something that can be safely ignored, or does it require further evaluation or treatment?
Right. So she has better to have a check on that if she didn't have it before and then develop again, because she has to check whether there is now, especially if it is associated with post-coital bleeding, that is after sex also she's bleeding, and in between we call it intermenstrual bleeding, but it is every day at the middle of the cycle, only one episode. I don't think she should be alarmed, because then usually it's a normal phenomenon, can be a normal phenomenon. But if it happens irregularly, and we call it in between two periods, she bleeds irregularly, and also especially after sexual intercourse, if she bleeds, she had to check her neck of the womb to see whether there is any, we call it polyp, ectropy, and so many, variation, but you have to check and see.
All right, thank you, Professor, for that insightful information on mid-cycle spotting. So next one is in Sinhala. මේ කාන්තාව කියා සිටිනවා ඇගේ බබාට මාස 5යි කියලා ප්‍රසූතියෙන් පසුපස මල පහ පිට කරන ප්‍රදේශයේ මස් කැල්ලක් එල්ලෙනවා වගේ අතට අහු වෙනවලු. මේ ප්‍රසූතියට මාසයකට දෙකකට කලිනුත් තිබුණා කියලා ඇයට මතකයක් තියනවලු. ඉතින් අපි පැහැදිලි කරලා දෙමු ඇයි මෙහෙම සිදුවෙන එක සාමාන්‍ය තත්ත්වයක්ද, ඇය මේ පිළිබඳව සැලකිලිමත් විය යුතු කෙසේද කියන එක සම්බන්ධයෙන්.
ඒ ලක්ෂණ අනුව එක අපි කියන හිමරොයිඩ් නැත්නම් ආර්ශ සමාරෝහ කියලා. ඉතින් ඒක විශේෂයෙන් ප්‍රෙග්නන්සි, ඒ කියන්නේ ආර්ශ සමාරෝහ කියන්නේ අපි කියන්නේ ගුද මාර්ගයේ වාට තියෙනවා මේ අපි කියන ලේ පිරුණු සැක්ස් වගේ. ඉතින් ඒවා එළියට එන එක. ඒක ප්‍රෙග්නන්සි කාලේ ටිකක් වැඩි වෙනවා. ඒ වගේම අපි normal delivery සීස කියලා ලොකුට වෙනස් වෙනවා. නමුත් normal delivery චුට්ටක් වැඩි වෙනවා. ඒක අර මොකද පුෂ් කරන හින්දා. නමුත් ඊට පස්සේ සති 6ක් යනකොට ඒගේ normal හිටපු තත්ත්වයට එන්න ඕනේ. කියන්නේ pre pregnancy state එකට එනවා. චුට්ටක් වැඩි වෙලා තියෙන පුළුවන් අර ඩෙලිවරි එකේ සහ ප්‍රෙග්නන්සි කාලේ ඇති වෙච්ච චේන්ජස් හින්දා. බට් ඉතින් අර්ශ සමාරෝහට ට්‍රීට්මන්ට් එකක් ගන්න ඕනේ. මොකද වේල පහින් ට්‍රීට් කරන තරමට ඒක ට්‍රීට් කරන්න ලේසි. මොකද එන්න ඒකේ කොම්ප්ලිකේෂන්ස් වැඩි වෙන හින්දා. ඉතින් ඒකට අපි කියනවා ජෙනරල් සර්ජන් කෙනෙක්ව හම්බ වෙන්න ඕනේ. ඒතකොට ඒගොල්ලෝ බලලා ඒකට ප්‍රතිකාර ක්‍රම ගොඩාක් තියෙනවා. ඒ වලින් එයාට සුදුසු ප්‍රතිකාර ක්‍රම ඒගොල්ලොත් එක්ක ඩිස්කස් කරලා කරගන්න පුළුවන්. ඉතින් ඉම්පෝර්ටන්ට් වෙන්නේ ආය රිකරන්ස් වෙන්න පුළුවන් හින්දායි සහ අනිත් ඒවා දෙකක් තියෙනවා තව එන්න පුළුවන්. ඉතින් අපි කියනවා කොන්ස්ටිපේෂන් නැත්නම් මලබද්ධය අඩුවෙන් තියාගන්න ඕනේ. ඉතින් හොඳට වතුර බොන්න ඕන අඩුම ලීටර් 3මාරක්වත්. ඒ කියන්නේ සතියේ 3-4 දෙපාරක් 3 පාරක් හොඳ රීච් පැපොල් ගෙඩියකින් භාගයක් කන්න. ඒ වගේම එක වේලක්වත් බත් එකකින් භාගයක් මැල්ලුමක් කන්න. ඒ වලින් අපි කියනවා කියන්නේ කොන්ස්ටිපේෂන් 80 විතර අඩු කරගන්න පුළුවන්. ඊට අමතරව සමහර අයට ඒවත් වෙලා තියෙනවා නම් තව බෙහෙත් පාවිච්චි කරන්න වෙනවා කොන්ස්ටිපේෂන් එක. ඒකට මේක තව වැඩි වෙන එක සහ තව අලුතෙන් එන එක වළක්ව ගන්න පුළුවන්.
බොහොම ස්තුතියි වෛද්‍යතුමනි ඒ දැනුවත් කිරීමටත්. ඊළඟ ප්‍රශ්නේ ඉංග්‍රීසි වලින් අහලා තියෙන්නේ. This lady says she's 33 years old and she has had her son via forceps delivery 3 years ago. Since childbirth, now she has difficulty controlling bowel movements. For example, she feels the urge and often cannot hold it as before. So initially she had thought it was normal, but now she thinks that it's not common. So she wants to know how to address it or manage it and whether it's curable. And to the benefit of everybody who's watching, can you also explain some bowel-related symptoms that may signal an emergency situation or need immediate medical intervention as well?
Right. Okay. So now, to answer a question in a brief way, she has to go and see her, immediately, because it's not normal. That's number one. Very likely, she probably sustained a injury to her anal sphincter, which is there is a muscle which keep everything close. So there is a damage here or somewhere during the forceps below, or there's a tear. And whether I don't know whether she was sutured in the correct way, or even if it is sutured in the correct way, then sometimes it happens. So usually, if it is persistent after 6 weeks, she should be under medical supervision. She may need another repair, sometimes by the colorectal surgeon. It's a kind of a serious thing at young age. Now, after childbirth, especially after vaginal delivery, or sometimes even rarely in cesarean section, having problems with bladder and bowel is common. And within the first week, it should get better. And if it is persisting after 2 weeks, you have to start investigating. If it is after 6 weeks, it's a must that has to be sorted. That's number one. Number two is that sometimes, when you have a tear, we call it 3A or 3B or 3C, where there is a damage. Depending on how bad the damage is, we kind of give a classification. If it is only Less than 50% we say 3A, more than 50% is 3C, and throughout the whole thing muscle get damaged, we say 3C. So that has to be sutured in a very particular way in the theaters usually, or even in the room we can do it if she's under proper anesthesia. And that sometimes it can be missed, right, wherever in the world, because sometimes you see the tear top, but there's a underneath tear also has happened where we can't see it, right? So she has to know whether what happened exactly, and for the current situation she has to seek medical advice soon and sort it.
All right, thank you very much, doctor, and I hope that really reassured the person who asked the question what to do next.
Just to add one thing for that, after especially after childbirth, especially after vaginal deliveries, one should start doing pelvic floor exercises. So 8 contractions in the morning, 8 contracts at night. It takes only 16 seconds. Contract, relax. Contract, you can feel the relaxation 2, 3, 4, 5, like that. Only 8. It takes only 16 seconds in the morning and at night. So when you wake up, before getting down bed, you have to do 8. And at night, if you do that until lifetime, you know that after 50, 60, these can happen. Problems with urinary incontinence, holding urine pass without knowledge, and also especially organ prolapse. The womb, bladder comes down. You can prevent them by about 80%.
Thank you very much, doctor. That's a very timely topic because we are coming next to bladder issues. So this lady has had a vaginal baby delivery about a year ago, and she says that when she sneezes or coughs hard, a little bit of urine passes involuntarily, and any reason that may cause this and how to manage it, including treatment options available. So I think you briefly touched about the Kegel exercises. Can you just answer the question as well?
Okay, come again. Sorry, I missed
so
one part.
Basically, this lady was having bladder issues where when she sneezes or coughs hard, a little bit of urine passes involuntary, and this is after childbirth. We have another one about post-hysterectomy as well.
Right. Okay. So still, as I told you, the same as the earlier answer. So if it is after 6 weeks, has to go and seek medical advice, because like this one usually can be managed by a proper pelvic floor exercises for about 6 months. It will get better, but she has to continue to do it until probably lifetime. And now usually when it comes to these symptoms like either bladder or bowel and persistent, and especially it's after a vaginal delivery, this usually contraindicates a subsequent vaginal delivery. So that has to be discussed with the relevant obstetrician, because there is about, like, let's say she got cured, and when she have a childbirth, there is a 25% or more chance of having a similar problem for life. So usually when this happens, now 1 week or 2 weeks it's there, then goes away, no issues afterward, that's a normal thing. But if it is more than that, especially after 6 weeks is persistent, that's a relative contraindication for a vaginal delivery in the future.
All right, thank you very much, doctor, for that. And this question is in Sinhala. මේ කාන්තාව කියා සිටින්නේ ඇගේ ගර්භාෂය මීට වසරකට පෙර ඉවත් කරන ලදී. දැන් ඇයට කැස්සක් කිවිසුමක් යන විටත් මුත්‍රා පිට වෙනවා කියලා. මේ සඳහා කුමක් කළ යුතුද කියලා තමයි අහන්නේ. ඒතර දැන් අපි කලින් සාකච්ඡා කරේ මේ දරු ප්‍රසූතියෙන් පසුනේ මේක මේ සත්කමකින් පසු ඒ දෙක අතරත් වෙනසක් තියෙනවද? මේක කොහොමද ඉදිරියට බලපාන්නේ කියන එකත් පැහැදිලි කරලා දෙන්න ඉක්මනට.
එතකොට ඒකේ කතාව තමයි කියන්නේ ගර්භාෂය කරපු හින්දා නෙමෙයි, ගොඩක් වෙලාට ඒක ඇවිල්ලා තියෙන්නේ. ඒක ඇවිල්ලා තියෙන්නේ එයා එක්ක ඉස්සෙල්ලා අපි දුන්නු normal delivery හරි මොන හරි වෙලා ඒක කතාවක්. එහෙම නැත්නම් simply because of අපි කියන්නේ මොනවාද ආර්ථව භාවය වෙලා ඊස්ට්‍රජන් අඩු වුණාට පස්සේ අර අපි කියන මේ බේසින් එක මේ වැටෙන්න ගන්නවා. ඉතින් ඒකත් එක්ක බ්ලඩ් එක වගෙනකොට අර අපි තද කරන ඒවා කරගන්න බැරි වෙනවා. ඒ නිසා ඒක ඔපරේෂන් එක කරපු ඉඳට වඩා ඔපරේෂන් එක කරලා තිබුණාටත් මේ කාලේ වෙනකොට යට ඒ දේවල් වෙන්න පුළුවන්. මම දන්නේ ඔපරේෂන් එක කරලා තියෙන හේතුව මොකද්ද සහ ඔපරේෂන් ලා විශේෂයෙන් ඩිම්බ කෝෂ අයින් කළා නම් මේ chance එක වෙන chance එක ගොඩක් වැඩි වෙනවා. නැතුව ඔපරේෂන් එක හින්දාම නෙමෙයි. එයාගේ ඉස්සර තිබිච්ච කළා ඒක එයා අපි තමු අපි කියන BMI එක high එක්කෙනෙක් නම් බාර වැඩි එක්කෙනෙක් නම් මේ chances වැඩි වෙනවා. ඒකට ඒක ඔපරේෂන් කළත් නැතත් ඒක විය හැකියි.
හොඳයි බොහොම ස්තුතියි වෛද්‍යතුමනි අපේ මේ ප්‍රශ්නට කිව්වොත් තව ප්‍රශ්න දෙකක් ඉක්මනටම ඇවිල්ලා තියෙනවා ෆයිබ්‍රොයිඩ් සම්බන්ධයෙන් ඒකටත් අපි පිළිතුරු දෙමු ඉංග්‍රීසි වලින් අහලා තියෙන්නේ එක්කෙනෙක් one has asked are fibroids age related and the other has asked do fibroids interrupt for pregnancy so if you can both answer these questions here that will be appreciated.
Good, right. So fibroids are very common, right? So like usually, even though it says age related, it means it's like they start very we don't know exactly when they start, but they keep on growing, and usually we start seeing them usually after 35 years of age. That is why people think it's age related. Now in our context, in the Asian population or in Sri Lanka, if you take 10 women after 35 years of age who have no issues, who are like living normally, doesn't have done any scans or anything in life, we just get them and do scans. 6 of them will have some sort of a fibroid. So as I told you, we are not worried about it. That's why I'm saying. And now we tend to see fibroid little early because people with subfluid and all that, we do transvaginal scan, and so we can detect them early. So the number one is don't do unnecessary intervention because that can do more harm than actual benefits. So as I told you, the prevalence of subfertility is 30%, or 30% women can't get pregnant, but prevalence of fibroids are 60%. So if the fibroids are causing subfertility, it should be 60%, simple as that. So you have to do other things, then only you remove fibroid if necessary. So some in rare instances where fibroids can cause miscarriages, preterm labors, but it's a rare phenomenon. Right, but it depends on the size and where the fibroid is. Right, sometimes there can be a 16 weeks or 16 centimeters, like a huge ball-sized fibroid. The woman even doesn't know it's there. But sometimes if the fibroid is inside the cavity, only 1 centimeter, she has profuse bleeding and all that, we have to remove it. So it depends on person to person and how it affects their symptoms. Only we need to treat.
All right, thank you very much, Doctor. And with that, we come to the end of our 4th live virtual medical discussion with Professor Probhodana Ranaweera, held in collaboration with Mums in Colombo Facebook page. So on behalf of all the women who benefit from these sessions, I would like to thank you, Professor, for dedicating your time to come here and answer questions related to women's health, pregnancy, and postpartum issues. Your dedication is truly appreciated. And also, I would like to thank all the ladies and our viewers who sent their questions as well, because those questions form the basis of today's discussion, and your questions don't just help you, but it also helps countless other women who may be going through similar issues as well. So thank you for all that as well. And remember, empowerment begins with education, and by staying informed, you're educating yourself and people around you to lead a healthier and a happier life. So until we meet again, stay safe and take care. Thank you.
Thank you, once again for inviting, and also for all the women who have joined today and asked questions, and also Taruka, once again for thank you, because we do all the back end organization. I have no idea what's happening. So actually now only I realize what happened. I have kicked the plug from down below on this thing. So now only we realize why. That's why. I didn't know that until a little while. Okay, thanks a lot, and thank you very much.
Okay, thank you, Doctor.
Okay.